Hi, I'm Dr. Stephen Fass, and welcome to my online seminar. For the next few minutes, I'd like to teach you a little bit about the basics of weight loss surgery. To get started, for a little nomenclature, we categorize patients that are overweight with a body mass index. Body mass index, or BMI, is a height-weight calculation that helps us determine who is or is not a candidate for surgery. Anyone with a BMI over 30 is considered obese. I am not a plastic surgeon. Weight loss surgery is a health issue. We know that people that are overweight do not live as long as people that are not overweight if you match them head to head. Why is that? Because obesity affects every organ system in the body. We call these comorbid conditions or comorbidities. Specifically, people that are overweight tend to have a higher incidence of type 2 diabetes, high blood pressure, obstructive sleep apnea, and arthritis. So the question becomes, if you are overweight and you have one of these medical conditions, and you lose weight, do those conditions improve? And the answer is clearly yes. So the successful treatment of your obesity can reduce your risk of dying, it can improve your quality of life, and reduce healthcare expenditures. The problem is that only 2 to 5% of all people can lose the weight and keep the weight off. So what are your surgical options? The first operation is called a laparoscopic adjustable gastric band, also known as the lap band. A lap band is a silicone device. It's placed around the upper portion of the stomach. On the inside of the band is a balloon, and that balloon is attached to a tube that goes to a port, so we can add or subtract fluid into the band. The band works by restricting how much food you eat. You still absorb everything you eat, you just eat less. On average, people lose between 50 and 70% of their excess weight. Unfortunately, tightening up the band can cause many problems. Specifically, it can cause reflux or dilation of your esophagus, which is the tube that leads to your stomach. Other problems of the band include slippage, an erosion of the band, or problems with the port. Any of these could require a reoperation to fix. The second operation is called a vertical sleeve gastrectomy, or a gastric sleeve. With a gastric sleeve, we use a stapler to divide and remove a portion of the stomach, leaving a smaller portion of your stomach remaining. It works by restricting how much you eat without many of the problems associated with a foreign body. On average, patients lose between 60 and 80% of their excess weight, oftentimes much faster than the band patients. Problems with the sleeve early on can include bleeding, a staple line leak, or cutting the sleeve too small. Many times I invert the sleeve to prevent some of those complications. Fortunately, we don't know of any long-term problems associated with the gastric sleeve. The third operation is called the gastric bypass, also the Roux-en-Y gastric bypass. With this operation, we divide and create a small upper pouch of your stomach and then reroute the intestines to that portion of your stomach. It works because the operation will restrict how much you eat. Also, your food doesn't meet your digestive enzymes till later downstream, so you don't absorb everything you eat, giving it a malabsorptive component. Weight loss is between 60 and 80% of your excess weight and also tends to be very fast. Early problems with the sleeve can include a staple line bleed or leak. Long-term problems can include a stenosis or stricturing of that staple line, ulcerations, bleeding, and even an internal hernia. Gastric bypass and sleeve patients are required to take vitamins to help with their nutritional needs. In addition, patients that have the gastric bypass can develop something called dumping syndrome. About 3/4 of all patients develop a stress reaction to sweets. With this phenomenon, after eating a sweet, patients can experience nausea, vomiting, bloating, and even diarrhea. All three of these operations require a lifelong commitment to change and can be defeated with high-calorie liquids. When putting these operations head-to-head, band and sleeve patients only have a restrictive component to their surgery, whereas the bypass also has a malabsorptive component. All three operations are done laparoscopically. The band is reversible and adjustable, whereas the sleeve and the bypass is not. Hospital stay, on average, is 2 nights for the gastric bypass, and either outpatient surgery or 1 night for the band and sleeve patients. All patients tend to return to work between 1 and 2 weeks after surgery. As mentioned, the weight loss tends to be much more rapid with the gastric sleeve and the gastric bypass as opposed to the band patients. Having weight loss surgery is a big decision for you. I deliver highly personalized care. I see you before, during, and after surgery. never turn you over to a mid-level provider or another surgeon. Thanks for viewing my seminar, and welcome to a new beginning.